Yeah, that way. Okay, so the rest can join us later. Um, so I think on associations and causality, and that is where we broke off. So this afternoon lecture will be continued from associations and causality. In public health research, it's always important to determine whether there is a given association, and if the association exists, whether it is a causality. And these are principles that are supposed to stand on two basic assumptions. The first assumption is that human diseases does not occur at random. At least for that fact, we know from cause postulate that before a disease can manifest, there must always be a causal relationship between a particular microorganism and a disease they cause. That is one. And then this is all to say that without a particular microorganism, a disease possibly cannot manifest. It's also another established fact. But the understanding of this takes us to the realm that there must be an association between a living pathogen and a disease they cause. And if there's an association, are they causal? Do they cause a causal effect? And those are the things that we're trying to understand as we make progress from our lecture where we stopped from last week. So I said, an association exists if two variables appear to be related by a mathematical relationship. So what it means is that a change in one area must also dovetail another change in another area. So a change in an input is supposed to cause a change in an output. So we are saying an association necessary for a causal relationship to exist, but association alone, as it were, does not prove that a causal relationship exists. And I remember giving an example of a person who has taken a vaccine and who has traveled on a vehicle from, let's say, Sunyani to Kumasi and have gotten an accident. Are we going to link the vaccine shot taking to the accident that has occurred? That is also another matter. And so we said events are said to be associated when they occur more frequently together than one would have been expected by chance. So for instance, if it so happens that people who drink driving from Kumasi to Sunyani often get accidents, and these occurrences happen in repeated cases. If you occur in repeated cases, then we cannot possibly leave it to chance, then we can say it's a causal relationship. So if two attributes, say A and B, are found to coexist more often than ordinary chance, then it is useful to consider the concept of correlation. And so we say correlation indicates the degree of association between two variables that has been established. So we have correlation coefficients that ranges from minus 1.0 to 0 to 1.0. Values of 1.0 means that two variables exhibit a perfect linear relationship. Whereas we know causation implies correlation, but correlation does not always imply causation implies correlation, but correlation does not always imply causation, which means causalities. So I've shown you this diagram where I have my no linear zero, linear relationships, strong positive, linear relationships, strong negative. If two factors, let's say people who smoke marijuana end up being mad, then we can say marijuana smoking and madness, there is a correlation, and this correlation can be positive. However, if we say people who smoke marijuana do not often get mad, then we can still link marijuana smoking to madness. But because they are not often getting it, then that can also be a strong negative correlation. Let's see how negative correlation is explained in terms of inverse relationship. So we say the magnitude of one variable appears to move
in opposite direction of other associated variables, then this we can easily say it is a reverse or negative association. But then when there's a positive association, where the magnitude of both variables appear to move together, either down or up, then it is also safe to say the correlation coefficient is positive. And if the relationship is causal, then we can say higher levels of risk factor can cause more of the outcomes to occur. You must also know that sometimes there can be association that could be spurious. Some can also be indirect, and there are some that can also be direct, where direct means one-to-one or multifactorial. Let's see how they explain it. Spurious association. Spurious association appear due to an improper comparison, or as it were, a selection bias. Here, it is observed that the association between the disease and a suspected factor may not be real. For example, somebody can say, oh, I went to lecture room today and I was bitten by a mosquito in the morning. In the evening, I have headache. And so I have malaria bitten by mosquito. This could be spurious. Spurious because the comparison can be biased or it can be improper. Especially from our background where we know it is only an infected female Anopheles mosquito that can possibly cause an individual to have malaria. Yeah, just give me a Right. So then we also see the ringing of alarm bells and the rising of the sun. Can you say the alarm bell ringing causes the sun to rise? This association is very spurious. Every morning the cocks crow and the sun rises. Can you say that as a result of the cock crowing, that is why the sun is rising? They are never related in any form. And this could be a spurious association. Let's look at how they differ from indirect association. And so if association occurs and its occurrence is due to the presence of another factor, which is common to both, then we can say both are known as confounding factors. For instance, we can say that drinking coconut oil can cure diabetes. But then a person may not be drinking only coconut oil. Although the person is eating coconut oil every day, his or her diabetes is going down, there can be other co-founding factors or confounding factors that is also contributing to that. So for instance, is the person eating maybe pepper in addition to the coconut oil? Is the person eating Maggi? What is the age of the person? What is the sex of the person? What is the social status? So if there's a situation that cannot be linked directly by two factors put together, but there are other co-factors occurring, then we say, oh, there are other co-founding factors, and these could alter the explanation that we have. And so we say statistically, association between the characteristic of interest and then due to the presence of another factor, example, a common factor, that is not linking the two together, could be co-founding variables. And just as I said, age can also come into play, the sex of the individual, and even his or her marital status. So we are saying a co-founding factor or a confounding factor must first of all be linked with exposure first of all. And before you can be considered as a co-founding factor, you must be independent risk factor for the disease, but then you're also connected in a way. For example, people who are exposed to some chemical reagent end up getting lung cancer. It has been established. But then you realize that within this cohort of people, some are smoking. Would you say the smoking is a co-founding factor to the exposure to chemical? Because there are also some other people who also don't smoke, who still get the lung cancer. And so in that effect, the smoking that sits in the middle becomes a co-founding factor, limiting the direct linkage between the exposure and then the outcome. Same also happening for people who smoke, ladies, and people who get cervical cancers. There are some analogy that says that once you are smoking, you are making your cells oncogenic and it could trigger cervical cancer. But then most people who get cervical cancer also end up having multiple sexual partners. And so here, sexual behavior or the number of sexual partners becomes a co-founding factor between smoking and cervical cancer. Let's look at the direct association that is common to us. So by direct association, we are saying one-to-one causal relationship. And this model suggests that two factors, A and B, exhibit one-to-one relationship if change in A is automatically followed by a change in B. For example, having unprotected sex with a woman who is ovulating, leading to pregnancy. The moment the person has sex with a woman who is ovulating and is unprotected, and there is pregnancy occurring, then you can say having sex unprotected with a lady who is also ovulating could be a direct relationship association for the establishment of pregnancy with respect to sex. Let's look at multifactorial causations. So as the name implies, multifactorial means that a number of factors come into play. With the direct, we have 1:1. But the moment it becomes multifactorial, then it means one to many. In several modern disease escapade, more than one factor is implicated in the web of causation. Example, we know from research that exposure to asbestos and smoking can cause lung cancer independently. However, our knowledge on disease has increased, and now we may tend to discover that in spite of the asbestos exposure, there is a common biochemical event that can be altered by each of these factors, and this, as I said, can lead to this lung cancer. So we say exposure to asbestos is one, but then there are also some biochemical processes, which means that it is not only exposure to one factor that leads to the disease. And all this explanation is so crucial because anybody who is a microbiologist will tend to also look at some aspect of public health, and these are more explained so that you don't make your informed decisions openly and you don't make these excuses openly where you also incur the displeasure of the people who you intend to make your presentation to. Any question after this one? Yeah, any question? The last time we didn't get a chance to ask questions. If there isn't any question, let's quickly make note because we have a lot to cover. Let's look at cause. Let's look at cause. A cause is always important when it comes to disease manifestation. The good thing is that all of us understand what post-causally stands for. And he is always of the view that anytime a disease manifests, there is a presence of a pathogen that is a cause postulate. And the cause postulate had its ideology from the theme cause. Now, what is a cause? in public health or global health. Cause is simply a combination of necessary and, if you like, sufficient factors that include attributes in exposure, and the presence of which, either alone or in combination, at some time during an individual life, inevitably result in disease in that individual. That is a cause. So a cause could be exposure to a pathogen. A cause could be a behavioral lifestyle. A cause could be one dietary lifestyle. And even a cause could be one's marital status, religion, or living income level. But then we have necessary cause and sufficient cause. Are they the same? No. What is a necessary cause? Necessary cause is simply a risk factor, and this risk factor must be or have been present for the disease to occur. So a specific infectious agent for a particular infection to occur. So you cannot tell me that you have COVID-19 without being exposed to SARS-CoV-2 virus. And here, exposure to SARS-CoV-2 virus is a necessary cause. Now, how different are they from sufficient cause? Now, with respect to sufficient cause, we are saying is the minimal combination of risk factors, either acting alone on individual or an etiological agent, if one is involved, or in an environment whose occurrence in an individual's lifestyle inevitably will end up resulting in a disease. And here, a disease is often caused by more than one set of sufficient causes. The different causal pathways for individuals having the disease in different situations will also come to play. So for sufficient cause, we are saying it is either the minimum requirement that one needs. What the necessary cause also talks about a factor that must be present before a particular disease condition can occur. So the necessary cause of a disease would automatically differ from the sufficient cause. And all of this, we're looking at the magnitude of causalities that come into play before a disease is presented. So we say necessary cause is a cause factor whose presence is required, and I outline the word require for the occurrence of the disease. So if the disease is not developed without the factor being present, then we term the factor necessary. Example, Plasmodium parasites being responsible for malaria. So here, Plasmodium parasite becomes a necessary cause because without Plasmodium, you can never be diagnosed of having malaria. Sufficient cause. We also say it's a minimum set of conditions, factors or events required to produce a given outcome. Usually, when there is no sufficient cause because it's always real in theory, but then it's often real, probably in practice, but in theory, it exists because once we say it is sufficient, then it is enough to trigger a particular disease. So we are saying the factors or conditions that form sufficient cause are called the component causes. And so the necessary causes plus the necessary component causes would always result to the sufficient cause required to cause a disease manifestation in a healthy individual. So these are criteria for causal associations based on two people who are global health experts who align this in 2 different years. So there's a Surgeon's General Report, and they are saying its consistency. We are saying its strength, especially the dose responses. As we increase the dose, does it elicit an output response? How specific they are, its specificity, how it changes over time, we call it temporal, and then how coherent it, we also say in terms of the way they are expressed, compared to the strength, consistency, specificity, still, temporal relationship, which is still time. Then there's also biological gradient, biological plausibility, coherence, experiment, and even analogy. And these are all criteria for causal association that must be understood within their own remit, and so they can be applied as and when needed in global health. So let's quickly look at guidelines for causation. What are the guidelines for causation? How can we easily associate a guideline for causation? So Bradford Health, he in 1965 came out with a suggestion that the following aspects of an association considered in attempting to distinguish causal event from non-causal associations. So they look at the temporal relationship. Temporal relationship means time, okay? So an action occurring now, an action occurring maybe in 10 years' time. Are they possible to elicit some causal or non-causal associations? Biological plausibility, how plausible an event happening can lead to the expression of an outcome. Then the consistency. Does the event occur once? Are you bitten by a mosquito once for us to say there's a causatives? Then the strength of the association. Is it direct? Is it negative or positive? Then the dose-response relationship. As we increase input A, are we having a visible exponential increase in the output? The reversibility. It means once we are giving somebody water containing arsenic, the person is getting sores on the body. If we decide to even reduce the level of arsenic in the body or begin to withdraw acidic content in their food, will it change the narrative? That is experimental reversibility. And then specificity. When we introduce one specific pathogen into a given organism, will it elicit a given clinical symptoms, then even judging the evidence that has been produced. And these guidelines are key and they are so important if you need to understand how to distinguish between causal relationships from no causal relationships. Let's look at temporal. So temporal, I said temporal normally refers to time. So temporal refers to a necessity for a cause to precede an event in time. Okay, so exposure to a factor must have occurred before the disease develops. Here, time comes in. Then let's talk about the length of the interval between the exposure and the disease manifesting. Very important. Remember, I gave an analogy of you bitten by a mosquito in the morning and you having headache and say the mosquito that bit you in the morning is giving you malaria in the evening. It doesn't work that way because we know the mosquito parasite go through the cycle. Now, if the disease develops in a period of time too soon after the exposure, then the causal relationship is called to a question. I think I mentioned that. Now, this is usually self-evident because although it's difficult, it could arise in the case control. Especially for case control, I can decide that I am exposing a given cohort of people some amount of COVID-19 vaccine or some amount of COVID-19 virus, and I'm expecting to see their body temperature change within 15 days. It is possible. It is possible, but it also depends on the case you are looking at. And this can become a case control scenario where you are looking at the cross-sectional studies with measurement of a possible cause and effect made at the same time. And in fact, that may also in fact alter the exposure, also occur within a very short time. An example has been used in the case of a seatbelt. So wearing seatbelt, and people also dying in accident can all be related. But like we said, temporal or time relationships are so crucial and they must be understood within that realm. Let's look at biological plausibility. What is biological plausibility? As biologists, when we talk about biological plausibility, we can explain that it is an event that is more likely if it's consistent with other knowledge. And so that situation must be consistent with the other knowledge. Example, mechanism of action, evidence from animal experiment, etc., etc. Do we have problems with plausibility? Yes. Sometimes when we are too much skewed to biological plausibility, we are often not, it is too often not based on logic. Here, the reasoning portion is taken away because you think that once an event occurs, automatically they must elicit a response because there is some element of biological plausibility, and so there is some element of proud belief, lack of which may be a simple replacement of medical knowledge, which could also throw your whole view or result you have overboard, thereby throwing the results that you are expecting based on the biological plausibility to the wind, and it could have some global health implications. Let's look at consistency and replication. Consistency. It refers to repeated observation of an association in different populations under different circumstances obtained from different time. For instance, we can take the case of my own son Joshua, for example. We can say Joshua is always late. Why? He's late in joining the Zoom lectures. He's probably late in joining face-to-face lectures, or he's late in joining group studies. Then we have said Joshua is late and he is consistent over time with different group of population. That is where consistency comes in. And so to be able to collect data and be able to say we can rely on this data, there must be the replicability of the data. And that is why we normally would suggest that you are going to take sample from a given population. You are going to take it once. When the sample size is small, go about 4 times. If you go 4, 6, 7, even 10 times, and you are getting a similar trend, then you can say consistently your data has been replicated, and so it can hold water. Let's look at strength. Strength. So there can always be strength in association, and there can also be weaknesses in association. Let's look at the strength. Mr. Health's argument is that a strong association between possible cause and effect are more likely to be causal than a weak association. I take it again. Hill's argument is that a strong association between possible cause and effect are more likely to be causal than a weak. Now, the fact that an association is weak does not rule out a causal connection. It is true. So there can be association between two variables. Weak as it may look, there's an association. It is. It is up to us to determine the strength. Association. The fact that association is not strong, that is also not there. Maybe existing, but just maybe the strength may be weak. So we are saying there are statistical methods to quantify the strength of association. And most of you have been using odds ratio, attribute risk, and even relative risk for a long time without knowing where it is coming from. So you cannot have odds ratio when you are not comparing between two groups. So maybe you are doing a study where you are comparing your variable from, let's say, committee A to community B. In committee A, maybe you have interviewed maybe 40 or even 100 people. In committee B, you have also interviewed maybe the same number of people. And then you are trying to compare across groups whether a particular factor that occurs common to them has an attribute between the two of them. Now, depending on your statistical packaging, your research question, you can either calculate the relative risk, attributable risk, or odds ratio. So most of the time, the odds ratio also talks about the strength of your p-value. So we say this is, if the p-value is less than 0.01, we say it's significant. If it's more than 0.01, we say it's not significant. But if it is less than 0.01 and you have 3 less than 0.01, do they have the same odds ratio? And that is why you need to use the contingency-based table to calculate your odds ratio. And all of this tend to test the strength of correlation between variables when you are doing analysis. So you are saying, what are the odds that the disease will develop in an exposed person? So disease developed, disease not developed. So for exposed person, for the disease to develop, we say it is A. Okay. And for the unexposed person, for the disease to develop, we say it is C. But for an exposed person, for the disease to develop, we mark it by B. And for an unexposed person, for the disease not to develop, we mark it by D. How do we therefore calculate an odds ratio? I've given you two scenarios. Scenario one, the odds that somebody who is exposed to, let's say, COVID-19, develop a disease is given by A over B, where A is the proportion of unexposed that develop the disease, but a proportion of unexposed that not develop the disease. So if you have the proportion of people developing the disease become the same as the proportion of people not developing the disease, let's say you have 2 over 2, your F ratio becomes 1. And so it cannot be compared. Let's look at the odds that an unexposed person develop a disease. The odds that an unexposed person develop a disease is also given by C over D. How do we therefore calculate the overall odds ratio? That is a proportion of people exposed developing disease over people exposed not developing the disease divided by people unexposed developing the disease over people unexposed not developing the disease. And mathematically, you can also calculate your odds ratio using this parameter. But all that I'm trying to say is that they also tend to describe extent to which two factors are comparable. Let's look at those response relationships. And so Ella is my TA. If I give Ella a dirty slap, I expect that Ella should fall on the ground. So what I'm giving to Ella is the dose, and the response is a sitting down. So if I increase the veracity or the velocity of the movement of my arm to her chin, the rate at which Ella drops must also increase. If that relationship is established, then we say there's a dose-dependent reaction. And so as we vary the dose, the response also changes. So we say a dose-response reaction occurs, or a dose-response relationships occurs when changes in the level of a possible cause are linked with changes in the prevalence or the incidence of the effect. So as the dose of an exposure increases, the risk of disease also increases. If the dose is present, then you say it is a very strong evidence for a causal relationship. However, the absence of a dose-response relationship does not necessarily rule out a causal relationship. For instance, I give Ella a dirty slap. She falls to the ground. I give Ella a heavier dirty slap. She still falls to the ground the same speed. It's still a relationship, and it's still dose response. We cannot say that because Ella did not increase the rate of her fall, there is no dose response. No. In some cases in which the threshold may exist, you keep on adding the slap at a point. There's what we call a saturation level. Even when you increase the amount of slap, the person will still fall the same level. And this is explained by this beautiful graph that I have here. Annual lung cancer death rates by the average number of cigarette smokers per day. So as they are smoking, it's also increasing. As they are smoking, it's also increasing. But it will get to a time that the number of sticks that you smoke could still not necessarily lead to a more number of people getting the lung cancer. So we say at this point, it is a saturated point. And that is why when you are taking your data, I also want to make sure that you don't overestimate your sample size. Because if you overestimate your sample size, you move into a saturation point where you are just wasting resources. Let's say you are undertaking a study and your sample point size calculation clearly shows that you need 800 people. You have gotten to 800. You are still going on to interview more because you think that the more you interview, the closer you can get to the reality. A point beyond 800, no amount of new people you tend to interview will give you a corresponding change in your result. Let's look at reversibility and cessation of exposure. Now, we are saying when the removal of a possible cause results in a reduced risk disease, then the likelihood of the association being causal is very strengthened. It is true. So, for instance, Mr. Sam likes bushmeat with a lot of salt. Anytime Mr. Sam eats bushmeat with a lot of salt, he feels that his feet are swollen. Mr. Sam decided, now I'm going to decrease the amount of my bushmeat I eat with my salt. If at the beginning of the year, I was eating maybe 1 gram of salt every day, now I'm reducing it to maybe 50 grams, 0.5 of a gram, then the amount of swelling decreases. Then we say reducing the exposure is also now reducing the response. And this can also be termed as a causal relationship that is very, very, very strong. If a factor is a cause of a disease, we would expect that the risk of the disease to decline when the exposure to the factor is reduced or eliminated is real. And that is also correct. And so we are saying cessation of smoking reduces the risk of developing lung cancer. And so this can be explained on the basis of visibility and even cessation or cessation of exposure. Let's look at the specificity of an association. An association occurs. They can be strong, they can be weak. They can be causal, they can be non-causal. But sometimes they can also be specific. Okay. Now, the weakest of all the criteria that we probably should consider eliminating is the specificity. Now, we are saying specific exposure is associated with only one disease. It's the most difficult to occur for 2 reasons. One, a single cause or factor can give rise to more than one disease. True or false? True. But more diseases are also due to multiple factors. That's also true. And so specificity supports causation. But then it must also be noted that the lack of specificity does not eliminate the disease all by itself. And this is used by tobacco companies to argue that smoking is not causal in lung cancer. And it is true. When I was in K University, there was a lecturer of us who was called Mr. Misa. He was a chain smoker. This man grew to the age of 70, was still teaching. He didn't have lung cancer. How can you therefore say that smoking would cause lung cancer? Then the argument lived to be said that the other causal factors that come into play to express the disease all by itself. So, example, not everyone who smokes develops cancer is true. Not everyone who develops cancer also smokes. It's also true. So we say if you have money, you must save. Otherwise, you can't build a house. It is true. But then it's not everybody who also has not built a house, has also maybe smoke or maybe enjoy himself. And this is a basic fact in public health that must be explained. And they explain on this basis of specificity. Let's look at judging the evidence. Judging the evidence. Sometimes there is no completely reliable means of establishing a causal relationship. And we have no option, but we show evidence that can be conflicting. So we say to make a causal interference, all available evidence must come into play. For example, what is the correct temporal relationship? And this is very essential before other criteria are considered. The timing of the dose, okay? Did the dose come in before the disease was expressed, or the person was sick before he was bitten by the mosquito? Temporal. Are there some biological plausibilities? Sometimes we also judge and see, are there consistency and dose response relationships? The likelihood of causal relationship here is likely when many different types of evidence lead to the same conclusion. So in summary, on the associations and causalities, bringing us to the end of this unit of our lecture, the lesson that has been, the lesson has revealed some of considerations, and these are empirical in making some causal inferences relevant to public health and global health decision-making and research we do. Results from some studies, especially epidemiologically, are often used as inputs for policy and for judicial decisions, and so they must be interpreted very carefully and within the remit of the academic rules that is so much deserved. Example, there are studies on link between smoking and lung cancer, and they have led to the labeling of cigarette packs. But that's important for public health and policymakers to also understand that some fundamentals of causal interferences also exist. And once they are identified, they must be looked at very well. So as I try to conclude, I'll try to say association does not only imply causation. It is true. Once an association, it can be that there are no causation. So for instance, people who are taking the vaccine, traveling from Kumasi to Sunyani and get an accident, 4 or 5 cases could be reported, but they can never be causalities. Apart from outbreak investigation, no single study is capable of establishing a causal relationship or fully informing other individuals or policy decisions. And those decisions should be based on a careful consideration of the entire relevant scientific and policies. So this is where we bring our lecture to the end of this model. And as I prepare for the next model, I would open the floor for questions, if any. Are there any questions? Hey, you why are you there?
Prof, we are here.
So I need to hear your voice. Yes.
I think I'll ask a question.
Who mentioned Ella's name?
Hey, Mr. Sam, I'm okay.
Is that some? You have a question? Ask your question. Why are you calling Ella? I can see you guys are tense with your exams. But you should take it easy. You should take it easy.
Okay.
Yeah, the good thing for you is that you are using your service time to do your masters, and that is a plus. So although you will be tensed, the reward is that next year when your colleagues begin to buy forms to do their masters, you will be on your way to finishing. And so as I keep on saying, the world is ruled by who? Ella.
Hired people.
So you must be tired. You must be tired. So taking myself as an example, since Monday I've not been well. I have not been well. I realized that I have had multiple hiccups. What do you call the potrico for like 3 days? It's not easy at all. I take medication and then it's only today that I've been able to write. But I'm also thinking about you because I don't want your lecture to delay. I'm thinking that at least if you can handle at least 3 different units today, then I can give you the slides so that you can start reading. And then when we meet for even another 2 hours, then we can bring our lecture to a close. So we will continue on the unit 2, which is the principles of public health. Okay. The principles of public health. So most of you who are my peers who have been teaching with me know that one of my research area is water, sanitation, and hygiene. And it's a very popular area that I would suggest that anybody who is doing environmental science, at least those of you who do microbiology, you must also try to find a niche because there's a lot of money in there. But unfortunately, when I came to UNE, I was supposed to have stayed in school of engineering, but I moved to biological science to start biology and then the life science. So all my WASH attributes was forgotten. But those of you who intend to probably stay in the Department of Environmental Science, then I'm thinking that water, sanitation, and hygiene must be an area that must be of interest to you. And you can't look at water, sanitation, and hygiene, you're looking at some principles of public health. So you are looking at some public health significance of disease linked with excreta and water-related disease. So I'll start by saying WASH is water, sanitation, and hygiene. Now, people are afraid of water and sanitation because of the hygiene aspect. When we start the lecture, I'll be showing some amazing statistics that throw more light on diseases linked to water-based, water-washed, water-linked, and water-related stuff that is causing a lot of death, even more than malaria and tuberculosis. And so the main objective of this particular session, which is the WASH, is how we microbiologists can reduce the transmission of fecal oral diseases, and as it were, exposure to disease-bearing vectors that either acting alone or in combination can transmit diseases with epidemic potential, allowing people living with good health, dignity, comfort, and security. Now, when we talk about epidemiology, I say the disease in a community. So a medical doctor will look at only one person. The global health person, which you are likely to be one, you will look at a larger population. How do you keep a population safe? And the reason why you want to keep population safe is that there is a lot of fecal oral related diseases killing avalanche doses of people, and you want to be part of the decision makers who want to change the paradigm by making sure that you do research, really. So why is water and sanitation so important for we the health aspect? One, research has shown that a lot of disease arrive from poor water quality and sanitation. And I'm happy you did water quality analysis. Sammy, I was supposed to have taken you to Ghana Water. What happened? Sammy?
Prof.
Yes.
The letter didn't go early, and because we were done with the post, we wanted to reschedule it and use it as a field trip.
Okay, it's important because I'm using water quality. It's also emerging here because you can't be a WASH expert and not understand the practical aspect of water quality analysis. And that is the strength that I have. So apart from the microbiology aspect that I also do on diseases, I also understand the remnant of the environment and the diseases they cause. Now, diarrhea disease alone killed 1.6 million every year. More than malaria, measles, and HIV put together. And that is a bit scary. And so diarrhea diseases caused by contaminated water also contribute to malnutrition, a lot of respiratory diseases. This in total results in about 2.4 million preventable deaths every year, mainly children under 5, from a combination of these factors. Therefore, the WHO estimates that a tenth of global disease burden could be prevented by improving water, sanitation, and hygiene. Yes, Sammy? Sammy?
Hello, Prof. Prof, it seems the new slide is not being shared.
Oh, and I'm going over.
We thought we were changing over the PowerPoint.
Do you see it now?
Yes, it's clear now.
Okay, so sorry about that. So this is the main objective of the course. The fact that I said reduce the transmission of fecal oral diseases. And then I spoke about why sanitation and water is so important for studies in health and the statistics that followed. Does it have ecological implication, economic implication? Yes. A report has indicated that poor water and sanitation cost Indonesia $6.3 billion every year, an amount equivalent to 2.5% of their GDP. Huge. This is a country that uses less than 0.05% of their GDP on education, and 2.5% of their GDP alone, leading to poor water and sanitation because they are paid. Now, this shows that improving water sanitation is the most efficient public health intervention. And so, for such a people, if they want to increase the quality of lifestyle, the people that they live in, then they must aspire to also improve water and sanitation so they can improve health. Other consequences are when people are sick, they lose the work that the time that they would have used to work to make more money. Some of them have to miss the education opportunities. Some not go to school. Some official and unofficial healthcare costs are also incurred, and this can be a drain on family resources. So, in total combination, then I can easily convince you to move into area of water sanitation and hygiene. And this area, there's a lot of money in it. My supervisor, Professor Mrs. Yewa, who did biology first degree, did environmental science masters, environmental engineering, PhD, has really enjoyed a lot of money in that area. But unfortunately, I was more looking at the health aspect, and so I didn't really get to enjoy most of the money. But those of you who are coming up, especially those of you who may be looking at joining the Department of Environmental Science, then you can look at this area. So what is health? What is health? According to WHO, they define health as a state of complete physical, mental, and social well-being, and not merely the absence of a disease or infirmity. And it is true. When you go to UNER campus, there are a lot of people who are working mad. They are not working naked. They are working mad because mentally, they're And so the WHO will look at physical, mental, and social, and that would encompass water and sanitation related diseases. So what it means is that if your water is not too well, we can say you are not healthy. Let's look at the concept of diseases from public health point of view or from global health point of view. A disease will occur as a result of complex interaction between man, an agent, and the environment. That is the One Health philosophy. So for One Health, there's always an interplay between the human being, the pathogen, the environment where the pathogen finds itself. If you want to control diseases, we cannot target only the pathogen alone. We target the pathogen with the environment whilst we give the individual a vaccine. Now, a disease is an abnormal condition and they affect the body of an organism. It's a fact. But from the ecological point of view, a disease can also be defined as a moral adjustment of human organisms to the environment define itself. And all these three categories or definition of diseases are linked with some symptoms. So I'll take you to the epidemiological trend where we have the agent, host, and the environment with the vector sitting in. So the vector is the common denominator, taking the environment, agent, and the host. So if I want to explain it, we look at the host and its factors. So as a host, you are not defined by the disease you manifest simply because you are host, but you are defined by your age, your genetic susceptibility, how well you eat, how many doses of pathogens you were exposed to, whether when you were a baby you were immunized, and other general conditions. Then the agent, is it a bacteria, Mycobacterium ulcerum, or Mycobacterium tuberculosis, or a virus, hepatitis B, SARS-CoV-2, or even influenza virus, or a parasite, whether affected by schisto or even malaria parasite, then this tool without the environment doesn't also come into being. If you are an individual host and you are being impacted negatively by this agent through a vector, how is your shelter like? How is altitude? The place you live, how humid is the place? Your sanitation, your food supply. Do you eat kinky with a lot of okra without meat? Or you eat gobe with your normal eggs and your normal garnish tomatoes? Water supply, do you drink Vortic, Aquabel, or you even drink such that is polluted? The temperature, how overcrowded your area is, and even some essential services. All of these would constitute the epidemiological trend that leads to diseases manifestation. So if we are environmental scientists and we want to help in trying to protect a given population of disease, given population from disease by epidemiology, then we must understand all the factors and see where we can institute a barrier, what we call the hygiene barrier. For example, when you go to a community where people are open defecating, they enjoy it, they call it free range, responsibility, they don't cover it. But don't forget that as they don't cover it, there are people going to fetch water from this stream. Others go to the field, working in their hands, can pick this. Houseflies can still pick this. And all of these can be introduced into our food. And when they introduce into our food, we get sick. And when we get sick, we defecate and the cycle continues. How do we draw the barrier? Now, we can draw the barrier when we know how the processes occur. So, for instance, between the person defecating, we can block a barrier where we make sure that we dig manholes and there is no open defecation. If we're able to escape this and people get contact, probably with this young man getting contact through his fingers, then we can also ensure that we produce a barrier here where probably people can use hygiene, okay, by washing their hands with soap and water on a regular basis. If they miss it and this young lady is sick, we can still introduce another hygiene barrier where we can also still introduce hand washing. And so there was a study that showed that washing your hands in running water every day is more likely to save you from occurrence of some diseases. And when COVID came, and when COVID was at its peak, people were advised to wash their hands with soap and running water. And in that year, there were no cases of cholera. Typhoid cases went down. And these were all hygiene barriers that were introduced. And the same can be explained in this diagram. Let's look at common route of transmission of diarrhea. It's simple. Once you're having diarrhea, then it means you have eaten somebody's poop. It's implied. So somebody's poop contains the salmonella typhi and all the enteric bacteria causing you to have diarrhea would be coming from the feces. From the feces, they are either washed, from the feces, they are either washed in streams or they are washed on our farms, or these greenhouse flies would hover around these feces with their proboscis inserting the feces. They will now move from there. Or even a person who even open defecating does not even wash his or her hands. Now, without the proper washing of hands, then it means it can be introduced into their water, their food. And when that happens, an innocent person can eat it. And when he eats, diarrhea transmission starts and the cycle can continue. Now, to be able to control this, then there must what we call introduction of barriers. One health barrier that we introduce is the construction of a proper latrine. If a proper latrine is constructed, then it means even when it rains, water from this species will not get into this stream. Imagine the same way. When it's not getting into this stream, it means this woman will be safe. When this woman is safe, it means this boy drinking water will be safe, and this lady will not be sick. But don't forget, this same lady who was sick, who is defecating, starting the cycle. So introduction of these barriers are so important. So there is a creation of healthcare, construction of latrine, creation of spring safe water, domesticating our personal hygiene, and then the list continues. So the health population or the health hazard of improper excreta disposal leads to these conditions that I have listed here. So there is pollution of soil using feces, water gets polluted, food gets polluted, and there's a lot of flies being propagated because these flies will lay their eggs in the feces. The eggs will be nourished. One fly can hatch maybe 10,000 eggs on the feces. They will give rise to flies, and there is propagation of these flies causing pollution. So there are 4 categories of water-associated diseases that I want you to be familiar with. So you have the waterborne diseases, water-based diseases, waterborne diseases, and water-related diseases. Are they the same? No. What are the differences? So although I admit that all these are linked with water, they are different. Let's look at waterborne disease. Waterborne disease. Waterborne disease normally is associated with the drinking or injection of fecally contaminated water. Diseases caused by the drinking of water contaminated by human or animal excreta that possibly contain pathogenic microorganisms could include cholera, typhoid, amoebic and bacillary dysentery. There is also giardiasis, cryptosporidiosis, campylobacteriosis, shigellosis, viral gastroenteritis, and even cyclosporosis. And these are all linked with ingesting fecally contaminated water in waterborne disease. Let's look at waterborne disease. Waterborne disease, as the name implies, it has to do with washing. Okay, so then it has to do with the washing of your hands, the washing of your body, and the quality of the water being used. And so waterborne diseases can be said are diseases that are linked to water scarcity and the resultant poor personal hygiene as a result of skin and eye contact with contaminated water. These pathogens include Shigella, typhoid, and cholera, and non-intestinal ones that include the skin diseases like the yaws, trachoma, fungal infections, and the list continues. And these are all caused by water wash diseases. Let's look at factors for preventing water wash and water scarce diseases. So we say if we are looking at water factors to prevent this, then we are looking at non-contaminated water for hygiene, washing our hands with soap, washing our things with soap, using a fly vector control, using a fly last vector control, and no crowding. Do you know when I was a child, I didn't know when you are washing with soap and when you are washing and don't add soap, you are not cleansing your material microbiologically. I was just thinking that it was really the action of the soap that was making my things clean. But really, the soap has an antimicrobial effect. It kills the bacteria and makes your clothes more hygienic. Let's look at water-based diseases. As the name implies, water-based diseases are diseases where it is probably there is involvement of an intermediate organism whose life cycle depends in a pool of water. And that one must come to mind, telling you that water-based diseases water-based diseases. All right. So water-based diseases, we can have water-based airborne disease as one. These are diseases caused by pathogens that have a complex life cycle, and this involves in an intermediate aquatic host, which can be a whale or a snail. Disease caused by a parasite found in intermediate organism living in a contaminated water would include schisto or even guinea worm. And these are all called water-based ailment diseases. Key factors for preventing water-based diseases, like I said, safe drinking water supply, adequate drainage of stagnant waters. Key factors for preventing ailments, control excreta disposal, hand washing with soap, and non-contaminated, avoiding contaminated food consumption. Let's look at water-related diseases, which is the last of the 3 water-based water-related diseases. Water-related diseases, that is the water vector-borne diseases, we are saying it is a disease caused by pathogens carried by insects that live near water. And they don't live alone. They act as mechanical vectors. Water-related diseases are caused by insect vectors that include our own mosquito. They are not typically linked with lack of access to drinking water or sanitation services. And these include dengue, malaria, filariasis, onco, trypanosomiasis, and even yellow fever. Vector related to the disease: mosquitoes, flies, larvae, fleas, and even some ticks. Key factors for preventing water-related insect vector and excreta-related insect vector disease are adequate drainage of stagnant water, disposal of wastewater, excreta control disposal, safe storage of drinking water, and even vector control. Any question up to this point? So what I'm talking about here is the importance of hygiene to water and sanitation. And when I say water and sanitation is important because of the hygiene component and the fact that it causes a lot of diseases, killing a lot of innocent people, and for which reason they must research in. And if we can research in, we must know how they are caused. Once we know how they are caused, then we can always introduce the right interventions that are linked to make sure that we can protect a given population from avalanche doses of sanitation-related diseases. What is diarrhea? Now, there's a young man known as Curtis, and he has a friend known as Pancros. They together in 2003, they said hand washing with soap and water after contact with fecal material can reduce diarrhea disease by 42%. They have conducted a study, and it was published in this article. So maybe you could look at it, read it for more information on the said article. Now, there are some diseases that are caused by poor sanitation that I think you must be aware of, so that even if you are thinking of some project in the near future, it can also, as it were, inform your thinking. We have what we call ascaris. Ascaris is, I don't even think that these diseases I should go through them because these are normal diseases. Sammy, these are normal diseases that every biological scientist must be aware of. Yeah, so
Yes.
so we can save time. This is also scabies, which is a contagious skin infection that spread rapidly in crowded conditions and is found almost worldwide. Let them get some medication, give me some treatment.
Okay, Prof.
So there is a list of some sanitation-related diseases that do not really require our time because they are straight to the point. Because all of us did biology, or maybe majority of us did biology. Because majority of us did biology, I don't think we must waste too much time on this one. So I'll quickly go through. So there's malaria, which you know, malaria does not need any introduction. Hepatitis, all of you have done biology. So if I was teaching the engineering students, then I could spend more time go for them. They have not done virus, but you have. There's also typhoid. Typhoid does not need any introduction. I'll quickly scale. Then cholera. Then it comes to the end of model 2. I want us to look at 3 different models so that I can share with you. if you can even close by maybe 4:35, and we can maybe finish 1 or 2 models, then I know at least I can share with you. So when I meet with you, maybe I can have maybe some 1 hour or 2 hours with you, and then we will take it from there. Any question?
Okay, Prof.
Yeah, any question after this point?
Good evening, Prof.
Yes.
Please, can there be a situation whereby the various forms of diseases, in case of the waterborne disease, can co-occur at the same time?
It's possible. I mean, if you lose guard, you are eating cholera infested food at the same time to you are eating other stuff together. It will occur. But just that one would occur once, and then maybe another can occur maybe another time because of different incubation period of this disease. But if you lose guard and you are exposed to all these pathogens, I can assure you that all of them could manifest in your body.
Okay, all right. Thank you, Prof.
All right, okay. So I'm trying to share the next slide. I don't know whether you can see it.
Yes, please. It's shown.
Okay, yeah. So let's look at transmissibility and dynamics of infection. And this should not be too difficult for a biological scientist because, like I said, this course is taught to the engineers, okay? But for the purpose of information, you must also get them so that at least if one day you become a lecturer and you are teaching and you have the slides, you can also make amendments and you can also teach with them. So transmissibility and dynamics of infection. So as environmental science people who are also interested in global health, we are looking at transmission of a disease from one individual to the other. And so there is also dynamics of infection and there's also transmissibility. What is therefore is an infection or communicable disease? These are things you know already, but permit me to expatiate on it. So an infection is an illness due to specific infectious agent or its toxic product that arise through transmission of that agent or its product from an infected person, animal, or its reservoir. And that leads us to communicable diseases. Communicable diseases, my dear students, are just infectious diseases. Okay? And they are diseases that are capable of passing from one person to the other. And this can be viral, bacterial, parasitic, or even fungal disease. Here, the mode of transmission could include one of many types. You can have mucus, blood, even breath, saliva, and even contaminated surfaces such as doorknobs and other fomites. Let's look at common cold as an infectious disease. Common cold is the most infectious communicable disease, the fact. And I had common cold some few weeks ago. Then I'm having this other infection, probably because I have also been straining myself. I have. But what can I do? When you have a lot of students that you love, when you have Ella, and then you have Joshua, and they are always looking into your eyes. Even when you are tired, you have no option but to give them the dose. So I'll try and do my best. So common cold is also there. And these are all infectious diseases. Signs and symptoms of common cold, these are things you know already. Congestion, sometimes your eyes can be watery, your nose can be itchy, you feel tired, your fever can rise, you cough and a few headache, which quickly goes away. But they are signs to tell you that you have an infectious disease. So, or you have a common cold. So infectious and chronic disease. There is an infectious disease that can be chronic. So the disease can easily be spread from one person to the other, and they can live with you forever. Examples include HIV and even tuberculosis. So they can easily be transferred from one person to the other, and they live with you for your entire period. Hepatitis is also part of it. Most infectious agents that cause diseases are microscopic in size. They are called microbes. These are things you know already. Transmission of infections. So we say an infectious disease can be transmitted through different canals depending if it is respiratory, gastrointestinal, or even sexually transmitted. These are things you know already. You meet me to skip this one. When you read, you understand. Okay, is that okay? Is that okay?
Yes, Prof.
Good.
Yes.
How do we prevent infectious disease? You see, this is the reason why I advise people who are doing biological science to do environmental science, because the course is friendly towards them, okay, compared to people from other areas. And these are the people who can easily yourself, because most of the things that you are doing, I think you may have seen before. Now, to prevent infectious diseases, one should first of all recognize its characteristics, including how dangerous, that is violent, and distance traveled by the victims. The use of standard precautions like, covering your mouth during coughing, washing your hands, wearing condoms, and abstinence from sex if you're a young person are all means by which you can protect yourself from infectious diseases. Sterilization of instruments used and avoidance of needles exchange among individuals, especially drug users, can also contribute to control of infectious diseases. So these are common examples of some infectious diseases that you are very much aware of. That you are very much aware of. And so you could read through and then you will be fine. Let's look at chronic diseases. Chronic diseases, these are diseases that start and they span a long duration. They can be defined as a disease that have prolonged course. They do not resolve spontaneously, and which complete cure is also very not achieved. And this includes our own HIV, but some of them can be chronic and non-infectious, such as diabetes. Stroke and cancer are all chronic diseases, but they are also not infectious. What are some of the risks of chronic diseases? All right, give me some few minutes. Let me make some quick call. Okay, maybe one minute or so, and I'll get back to you.
Okay. All right.
Yeah. Where is my microphone? All right. So the point I'm trying to make is that these are what are the risk factors of chronic disease? According to WHO, 7 out of 12 leading risks to health are high blood pressure. Hope you are listening. High cholesterol, obesity, physical inactivity, and insufficient consumption of fruit and vegetables, together with high dose of alcohol and smoking, could account for more than half of the global burden of diseases. And these, in combination, they raise your high blood pressure, causing estimated 7.1 million deaths, with about 13% of global total loss, with at least 600 million hypertensive cases worldwide. And these must be known and they must be avoided if we want to improve our general health. And these are a list of non-communicable diseases and the factors that lead to them. How can we improve? So I advise you, eat well, especially if you can eat a bowl of food every afternoon like I do. Allow bear me witness. The food is balanced because there is vegetable in the soup, there is cow feet inside, there is vegetable, there is okra, and there is ginger. Am I lying? Even if I take it,
It's fruitful.
if I take it once a day, I mean, I know I'm eating healthy. Avoid tobacco as much as possible, but physically move around, manage your weight, try to prevent the control devastating effects of the diseases once you have them already, and this could be controlled. So let me see. Okay, let's look at transmissibility and dynamics of infection. When COVID came, you may have heard the word R naught several times. Some were saying the R naught is less than 1, R naught is more than 1, R naught is 1. What does it mean? We'll try to explain. Now, results from transmission of specific infection agent or toxic products from an infected person, animal, or reservoir to suitable host has the following presentations. Infectious disease epidemiology deals with events that are caused by an agent that can further be transmitted. Example, somebody having the measles, and this measles spreading to other people. So one person having a disease, measles spreading to maybe 1, 2, 3, 4, 5, and even 6 people. That makes it difficult. And so, as people, we should understand the types of transmission that we have. So we have one-to-one transmission. There are some diseases you can have one-to-one transmission. There are some diseases you can have one-to-many depending on the contact you have, distance of travel, and whether it's airborne or not. Now, for skin to skin, we can say one-to-one. From mucosa to mucosa, where you are having unprotected sex, one-to-one. You can say body fluids when you are kissing, or when a mother is giving birth to child, you can say one-to-one. But for droplets, you can never say that. Or example for diseases that are caused by aerosols. Aerosols are droplets of particles holding disease-causing organisms that can hang in a room for some time, maybe in an hour. So if such droplets, like this young lady blowing this air, is there for an hour, anybody who moves in this area without knowing can easily inhale, and then he or she can start an infection. So let's look at the types of transmission. You can't talk about types of transmission without looking at how it is done. And we'll start with the vehicle-borne. Vehicle-borne. Some of the vehicle-borne of diseases are food, water, and even termites. And here, termites are talking about physical objects that can carry infection like handkerchiefs, eating utensils, doorknobs, staircase rails, tables, and what have you. Vector-borne, malaria. One malaria can bite one person, and it can bite 4 different people. How well an infection spread depends on the organism and the host, the environment, and how do we measure how well an infection spreads? So that is where we look at the secondary attack rate and then the reproductive numbers. Therefore, the attack rate. The attack rate, AR, is a term that is used in the context of an outbreak or epidemic of an infectious disease. The attack rate normally measures the frequency of new cases over a defined period of time, usually the duration of the outbreak. Anita, are you there?
Prof, please, Anita is not part of this class.
Oh, okay. The measure of frequency of new cases over a defined period of time, usually the duration of the outbreak. So the number of new cases occurring over the duration of the outbreak, the population at a risk at the start of the outbreak. So example, cholera outbreak at a refugee camp can be given at 5,000, can be given by maybe 5,000 people in the camp at the start of the outbreak. 2 people develop, 5,000 people are in the camp at the start of the outbreak. Then after some time, 2,000 of these people develop the cholera. Whatever becomes the attack rate. The attack rate becomes the number of people developing the disease over the total number of people present. And that can be the attack rate calculation. What is the secondary attack rate? secondary attack rate. That is the secondary note AR is used in the study of the spread of infectious disease in a small community. For example, the proportion of those exposed to the primary cases that develop diseases as a result of the exposure. Let's look at the secondary attack rate. For example, let's say we have 147 cases of people infected with monkeypox virus. Now, the number of people who are shared, or number of people who shared a home with a case, that is one person, we are saying is about 834. Therefore, those exposed to the primary case, therefore become the 36 of these 834 people become infected with monkeypox. Now, if you want to calculate the attack rate, okay, is the 36 out of the 836 people over the 836 will give you this secondary attack rate. Note that some diseases such as measles have higher attack rate, probably because the rate of transmission of the virus is faster, more violent, and attack rate can also increase. At this stage, shall we take maybe some 10-minute break and then we'll come and continue. But if there is any question,
Hello, Prof. Prof, please, I cannot hear anything. The audio is not working now. Is it?
It's break.
Oh, it's break. Okay, sure.
Yeah, 10 minutes break. And that is
Okay.
All right, so clearly it shows the guy just locked the phone somewhere and then he was doing his business. That is what it means. Because how can you be on a lecture? We said we are breaking and then is that Amos? Or is that Amos?
Yes, Prof. It was Amos.
Yes, Prof, that was me.
Amos was just locked the phone on and then he was chilling somewhere.
Prof, no. The network here is really unstable. Sometimes it breaks. I thought it had broken for a long period of time. The Wi-Fi is a bit unstable. So I thought it had broken for an extended period of time. That's why I was surprised.
No. And Claudia also just joined. Why? Didn't you know we were meeting at 3, Claudia?
Please, I'm not ready on it.
Come
So,
again.
but I'm using my laptop to connect.
Okay. Because I'm not here.
Already on it.
I've not heard your beautiful voice. So how will I not say you are not on? All right, okay. But let's try and make some progress and see. Let's try and make some progress and see. So that is so far about the secondary attack rate. And the truth of the matter is that these nodes have been broken down to a very simple level. Very simple level. And so they look many, but it's been very loose. So it's something that you can easily read and understand. That is why I'm moving that fast, to save time for you and so to save time also for myself. All right, let's look at the let me see. Let's look at the secondary attack rates. That was what we were talking about. Secondary attack rates. So I said note. Please meet yourself. Secondary attack rates is context specific. It's not cast in stone. It depends on a number of factors, depending on the organism concerned, the intensity of the contact, the type of the contact, and even the stage of the contact. For example, we can have a higher secondary attack rate for household contacts than that for neighbors, because if you are within the same household, chances are that you can have a secondary attack rate greater than somebody who is your neighbor. Then the type of contact. Example, for Ebola, contact with bodily fluid gives a higher risk of transmission compared to skin contact. Then the stage of the contact. At what stage is your disease manifested? Are you at a stage where you are very infectious, probably after you have finished your incubation period and all that? And all of these will affect the secondary attack rate. Then we come to my favorite reproductive number. Reproductive number. What is the reproductive number? Reproductive number is simply the average number of secondary cases per case. So for instance, person A gets a disease, okay? How long does it take for person A to transfer the disease to person B who is in the middle? If person B becomes sick, how long or what is the rate at which person B transmits to person C? And this is known as the reproductive number. So we have the basic reproductive number and then the net reproductive number. Are they the same? No. The basic reproductive number is when all the subjects are susceptible. I take it again. When none of the subjects have been vaccinated, we talk about the R0 or the basic reproductive number. So when COVID came before the vaccination, we were always talking about the R0. But as soon as people started getting vaccinated, there were some form of immunity that were built. And so we started talking about the net reproductive number, which is the number at time t, which is changeable, and it varies with a proportion that is still susceptible. And it's given by R into bracket t, where t is the change in time. And it can also be denoted by R, RE, RN, and RT. They are all denoted as the net reproductive number. So the basic reproductive number, we are saying the average number of secondary cases per typical case in the total susceptible population. So our note will depend on the chances of an infection being transferred during contact, which is P. then the length of time of your infectiousness being D, and the rate of contact C. And so it's always given by the probability of infection being transmitted multiplied by the rate of contact and the time which one is infected. And that gives us the basic reproductive number. And so if a case is introduced into a fully susceptible population, then we say the R0 is always greater than 1. Then an epidemic will result. But then implication is that we need to control measures as soon as possible. So the R0 becoming less than the R0 becoming greater than 1 is always a problem. But if our R0 is declining, then it means we have chances that we are making progress. Now, if a case is introduced into a fully susceptible population and the R0 is given by less than 1, then an epidemic would not result. And so there are epidemiologists who are always calculating that the R0 in UK is given by this figure. And so there's no way malaria can become epidemic in malaria in UK because it's being always controlled. Let's look at the net reproductive number after some people have been vaccinated. The average number of new cases per case is the number of susceptible transmission per case. Now, the red box, as you can see here, it means these people are immune. And so because they are vaccinated, they do not become cases. Here, for every 2 people who are exposed, the R becomes 1 because an exposed versus vaccinated, exposed versus vaccinated. And so in this case, it is difficult for a pandemic to, as it were, okay. Let's look at this diagram, which is very common to you because we are biologists. So for every case of infection, there is the dislodgement of the microorganism to the system. Once it is dislodged, it is held firmly. They multiply, they incubate. And as soon as they finish the incubation, they begin to introduce symptoms. But then after a period, if they are not killed, they can kill the organism. And so incubation period is very crucial. And this is from infection to the first symptoms. And what I call the length of time between when the pathogen is introduced into an individual to a point where it begins to elicit clinical symptoms of an infection. And it varies depending on the immunity of the individual and the infectiousness of the pathogen. There is latent or pre-infectious and infectious period. Sometimes you can be introduced with a pathogen can enter into your system. They could be incubating, but not infectious, simply because the pathogen is there, their numbers are being suppressed, and so they are not producing symptoms. But as soon as they are able to get to a certain number where they begin to elicit symptoms, it means they have fully incubated and now they can cause an infection. After which time they die. So the latent period can be a fallow period where the organism probably is still in the system, but they are not incubating because probably other factors are controlling them. But the infectious period is the time during which infected person can transmit the disease. And this determines how infection will be transmitted in a population and how long to quarantine patients when a particular infection is involved. Incubation period vary from individual to individual depending on one's immune system and what have you. So these are average incubation period of diseases you are aware. These you have done in biology. I'll not waste too much time on them. What therefore is herd immunity? Herd immunity. I believe when COVID came, you guys heard a lot about herd immunity. Herd immunity because we were thinking that we needed to vaccinate a lot of people so that we can get the herd immunity. Herd immunity is the point at which the rate of new infection is controlled. So herd immunity or population immunity is the population of the proportion of the people who are immune to an infection, and it's sometimes called the herd immunity. Once the herd immunity is reached, the rate of new transmission is controlled. Now, there's a herd immunity threshold, and this is the percentage of the population that need to be mirrored for the disease to become stable, for every case to give origin to only one new case. And so when COVID came, we started immunizing people. The idea was not to immunize everybody. So as you can see, not everybody in Ghana has been immunized, but we need to get to a herd immunity where we could stop the case of new infection. Then these are some calculations based on herd immunities and some vaccination related studies. So ladies and gentlemen, I think this is where I will end my lecture. I have 3 slides which I want to share with you right now. Please, I'm begging you, everybody must get A in this course. So I'm giving you a slide right now. I have probably a slide or 2 which I will give you when I meet up with you, but I want you to start going through, start familiarizing yourself with them, because all the questions are going to come from the first of the slide. Make sure that you understand the slides. But before I go, I would want to open the floor if there are any questions, and then I'll quickly take them, please. If there are no questions, then we'll call it a day. I'll end the lecture now, and then I'll share the slide with Mr. Sam right away before I even forget.